Hi everyone, and welcome to our module on heart murmurs. A heart murmur is a cardiac sound that can be heard with the stethoscope, and the cause of heart murmurs is turbulent blood flow, which we'll talk more about in a second. And you should know that a heart murmur can be normal in many situations, but it can also be a sign of underlying pathology in the heart, especially valvular heart disease. When blood flows through a structure like a blood vessel or the heart, if the blood moves at a relatively slow speed, the molecules will form what's known as laminar flow. Laminar flow gets its name because the molecules are lined up in layers, one on top of each other, moving at a relatively slow speed through the structure. And you should know that laminar flow is relatively quiet. Now you might think that if you increase the flow rate, the molecules would just move faster and faster but stay in that nice linear type of flow, but it turns out that's not what happens. When you increase the flow rate past a certain point, the molecules start to swish and swirl around like I've shown in this picture at the bottom of the screen. That's called turbulent flow, and this tends to be very loud. And turbulent flow occurs at higher flow rates. It also occurs when there are narrow flow areas. So in many valvular heart conditions, there is a narrowing of blood flow through the valve and a very high rate of blood flow. So this is the perfect setup for turbulent flow, and that's why many valvular pathologies cause heart murmurs. There is a standard grading system that is used to describe how loud a murmur is when you listen to it. A so-called grade 1 murmur is barely audible on listening carefully. A grade 2 murmur is faint but easily audible. A grade 3 murmur is loud and easily audible, but it has no thrill. A thrill is a vibration you can feel when you place your hand over the patient's chest, and grade 1, 2, and 3 murmurs have no thrill. A grade 4 murmur is loud and has a thrill. A grade 5 murmur can be heard with the scope barely touching the chest. And finally, a grade 6 murmur is audible with the scope not touching the chest. So many times you'll hear murmurs described as 2 out of 6 or 3 out of 6. They are using this grading system I've shown on the screen. Some other descriptors used to describe heart murmurs are shown in this slide. So one of the most important distinctions between different types of heart murmurs is whether they occur in systole or diastole. Remember that systole is the time between S1 and S2, and remember that diastole is always a longer time period than systole. You can also describe murmurs by the change in the murmur intensity over time. So a holosystolic or pansystolic murmur is like what I've shown on the screen here at the bottom left. The intensity of the murmur is constant throughout the time when you hear the murmur. A crescendo murmur gets louder over time, a decrescendo murmur gets quieter over time, and many murmurs are crescendo decrescendo, meaning that the intensity of the murmur goes up and down during the cardiac cycle. Shown on this slide is one of the most important images for you to learn before you take your Step 1 exam. This slide shows the listening points where you can hear murmurs loudest based on the underlying etiology. In board questions, they will often tell you where a murmur is heard loudest, and if you know this slide, you can usually answer the question correctly. So let's start to go through these listening points one at a time. What's labeled A here is the aortic listening point. This is the second intercostal space between these two ribs here, and it's at the right sternal border. That's called the aortic listening point. It's also called the right upper sternal border, and that is where the murmur of aortic stenosis is heard loudest. And aortic stenosis is a very common heart murmur. At the same point, the second intercostal space, but at the left sternal border, that's called the pulmonic listening area. It's also called the left upper sternal border. This is where pulmonic murmurs can be heard. This is also where the murmur of a patent ductus arteriosus can be heard. One interspace down from the pulmonic interspace is called Erb's point. It's also called just the left sternal border. This is where you can hear the murmur of aortic regurgitation and also the murmur of hypertrophic cardiomyopathy. If we go all the way down on the right side of the heart to the fifth intercostal space and listen at the border, that's called the left lower sternal border. This is the tricuspid listening point. This is where tricuspid murmurs can be heard. This is also where you can hear the murmur of a ventricular septal defect. And then finally, if we go to that fifth intercostal space, but we go laterally out to the mid-clavicular line, this is the point in the middle of the clavicle, that is the mitral listening point. That is also the apex or point of the left ventricle. So at this point, this is where you can hear all the mitral murmurs like mitral stenosis, mitral regurgitation, and mitral valve prolapse. The point where you can hear mitral valve murmurs is also the point where you can feel the maximal impulse of the heart. So remember that I told you on the last slide, at the left fifth intercostal space in the mid-clavicular line, that's where you hear mitral murmurs. Also, if you take your stethoscope off that spot and place your finger on it, you should feel the impulse of the heart when it contracts. That's called the point of maximal impulse. It's also called the apical impulse because your finger is over the apex of your heart. The apex is the point of the heart, the base is the back of the heart here. Sometimes that point of maximal impulse can become abnormal, and that will be described in a board question, so you should be familiar with this terminology. When that point of maximal impulse, the apical impulse, is laterally shifted, that implies an enlarged heart. You can imagine if this heart drawn on the screen here got much, much bigger, then that point would move out further laterally compared to the midclavicular line. And in conditions where the heart is being heavily stimulated by the sympathetic nervous system, for example, infection or exercise, the point of maximal impulse is often described as hyperdynamic, meaning it is more forceful compared to normal. There are many so-called innocent functional murmurs that are caused by normal blood flow and that are not an indication of underlying pathology in the heart. Most of these are common in children. You can also hear them in young, thin patients. In both of these groups, it's very easy to auscultate the heart, and you often hear the normal flow of blood through the heart. Generally, these murmurs are soft, usually only a 1 or 2 out of 6, and these patients have no signs or symptoms of heart disease. And there are a number of these innocent murmurs that have been described. One's called the Stills murmur, there's a pulmonic flow murmur, there's a venous hum. You can read about all of these if you wish, but you should just be aware that these are not a sign of underlying pathology. For the rest of this video, I'm going to talk about pathologic murmurs, and the most important distinction between different murmurs is whether they occur in systole or diastole. Let's first talk about the systolic heart murmurs. These occur when the heart contracts or squeezes, so these occur between S1 and S2. And systolic murmurs include aortic stenosis. You can imagine that you need the heart to squeeze to drive blood across the aortic valve with aortic stenosis to generate a murmur. You also need systolic contraction of the heart to generate the murmurs of mitral regurgitation, pulmonic stenosis, TR, hypertrophic cardiomyopathy, and a VSD. In contrast, diastolic murmurs occur when the heart relaxes and fills, so these are between S2 and the next S1. And diastolic murmurs include aortic regurgitation, mitral stenosis, pulmonic regurgitation, and tricuspid stenosis. Diastolic murmurs are always pathologic. Systolic murmurs can be normal. Many of the normal flow murmurs are systolic murmurs, but if you hear a diastolic murmur, that is always a sign of some type of pathology in the heart. Now I'm going to talk about specific heart murmurs, and we'll begin with the murmur of aortic stenosis. Aortic stenosis is a systolic murmur. The murmur is a systolic crescendo-decrescendo murmur. It's also called an ejection murmur because the crescendo-decrescendo pattern is caused by the ejection of blood from the left ventricle. I'll play you an example of this murmur now, and what I want you to try to focus on most importantly is distinguishing that the sound occurs between S1 and S2, not between the longer pause between S2 and the next S1. If you can just recognize murmurs as systolic or diastolic, you're on your way to being better able to characterize them. In the modern era, we use echocardiography to determine the severity of aortic stenosis, but years ago, before echocardiography, physicians had to use physical exam findings to determine how severe the aortic stenosis was. So some of the classic findings of severe aortic stenosis are listed on this slide. If the peak of the murmur was late, that implied there was very slow flow across a significantly stenotic valve, and that implied a more severe stenosis. So for example, the crescendo-decrescendo pattern looks like this. If it begins to look like this with a peak that is much later in systole, that implies more severe disease. If the second heart sound was soft or quiet, this meant that the valve was so stiff it couldn't slam shut and generate much sound. That implied severe disease. And then finally, pulsus parvis e tardis is a classic physical exam finding of severe aortic stenosis. Parvis e tardis means weak and small, and this means a weak and small carotid pulse. If you place your fingers on the carotid pulse of a patient with severe aortic stenosis, the carotid upstroke will be delayed and slow, and it will be relatively weak. That's a sign of very slow blood flow across a stenotic aortic valve, and that is another sign of severe AS. In another video, I talk about hypertrophic cardiomyopathy, or HOCM, in great detail, but I just want to mention here that it has the same murmur as aortic stenosis, so oftentimes this must be differentiated from aortic stenosis by using maneuvers. And the classic maneuver to distinguish hypertrophic cardiomyopathy from aortic stenosis is the Valsalva maneuver. I will talk about this maneuver later in this video, but this maneuver decreases venous return and preload. That makes the murmur of hypertrophic cardiomyopathy louder and makes the murmur of aortic stenosis quieter because there is less flow across the aortic valve. Our next murmur is the murmur of aortic regurgitation. Aortic regurgitation causes a decrescendo blowing diastolic murmur. It's described as blowing because it sounds like air blowing through a tube, and it's a diastolic murmur, not a systolic murmur like aortic stenosis. I'll play an example of it for you now, and once again, try to just recognize that the murmur is occurring during the longer phase of diastole between S2 and S1, not between the shorter phase of systole between S1 and S2. Our next murmur is mitral regurgitation. Mitral regurgitation causes a holosystolic murmur heard best at the cardiac apex. And remember, the cardiac apex is usually found in the fifth intercostal space at the mid-clavicular line. I'll play you an example of this murmur now. It's a holosystolic murmur, sometimes called a pansystolic murmur. You'll notice that the intensity of the murmur is constant throughout systole. It does not go up and down like we heard in aortic stenosis. Mitral stenosis causes a diastolic murmur. It's described as a diastolic rumbling murmur, and it is preceded by a sound called an opening snap. The opening snap is caused by the thickened mitral valve leaflets opening in diastole. So it's a very difficult murmur to recognize just from listening to it, but I'll play it for you in a second, but try to think about what I've drawn on the screen as you listen to it. So what you're going to hear is the first heart sound followed by a gap, and then you will hear the second heart sound and an opening snap, and after the opening snap you'll hear that diastolic rumble murmur of mitral stenosis. On this slide, I've listed two high-yield facts about mitral stenosis. First of all, you should be aware that you cannot get a left-sided S3 or S4 in mitral stenosis. I talk about both of these heart sounds in another video, but they are both generated by rapid filling of the left ventricle. In mitral stenosis, filling of the left ventricle is slowed by the stenotic mitral valve that blood must flow across to get from the left atrium to the left ventricle. Therefore, you cannot have rapid filling of the ventricle, and you cannot generate a left-sided S3 or S4. The second high-yield fact is that the time to opening snap is associated with disease severity in mitral stenosis. To understand this, let's imagine that we hear the second heart sound S2. That is the beginning of diastole, and it's during diastole that you're going to hear the murmur of mitral stenosis. After some brief period of time in diastole, you will hear the opening snap. The time between the second heart sound and the opening snap is associated with disease severity. The reason for this is that because as mitral stenosis gets worse and worse, the left atrial pressure begins to rise. The left atrial pressure can be very high in severe mitral stenosis. In fact, mitral stenosis is famous for having some of the highest left atrial pressures you will ever see. When the left atrial pressure gets high, the mitral valve opens more quickly, and therefore the opening snap occurs sooner after S2. So therefore this time between S2 and the opening snap, the so-called time to opening snap, gets shorter when the disease is more severe. And I've written these things on the slide. Higher left atrial pressure in severe disease decreases the time to opening snap. Therefore, a short time to opening snap is seen in severe mitral stenosis. I won't go into detail on tricuspid and pulmonic valve disease, and that's because the murmurs of these valve lesions sound just like their left-sided counterparts. They are only heard in different locations. So at the left upper sternal border, this is the pulmonic listening point. So this is where you can hear pulmonic stenosis and regurgitation. And at the left lower sternal border, that's the tricuspid listening point, and that's where you can hear tricuspid stenosis and regurgitation. The murmurs, however, will sound the same in terms of whether they're in systole or diastole and their other characteristics. Carvalho's sign is a physical exam finding that can help you distinguish right-sided murmurs like those of the tricuspid and pulmonic valves from left-sided murmurs like those of the mitral and aortic valves. When you draw in a breath of air and inspire, most right-sided murmurs will get louder. That's because when you inspire, you're dropping the intrathoracic pressure that's transmitted to the right atrium. The right atrial pressure falls and more blood is drawn into the right atrium and the right side of the heart. This means that right-sided murmurs tend to get louder. Inspiration also tends to change the pressure in the lungs and hold more blood volume in the lungs, and that decreases the blood flow to the left side of the heart. So this means that there will be softer left-sided murmurs with inspiration. And the easy way to remember this, if you don't want to remember all the physiology, is just think of the fact that in general, inspiration draws blood volume into the lungs. So this is going to pull blood through the right side of the heart and make those murmurs louder, and it's going to deliver less blood to the left side of the heart and make those murmurs quieter. You can also remember Carvalho's sign by the fact that right-sided murmurs with the I increase with inspiration and left-sided murmurs with the E as the second letter increase with exhalation. A ventricular septal defect also causes a holosystolic murmur that can sound very similar to mitral regurgitation. Smaller VSDs have more turbulence because remember what I said before, small areas for flow generate turbulence, so they tend to be very loud. They also tend to be asymptomatic, so a person who has a very loud murmur with no symptoms may have a very small VSD. On the other hand, patients with large VSDs may have no murmur, but they can be very sick from right ventricular overload from a large VSD. So a VSD causes a holosystolic murmur, and you always want to remember the three causes of holosystolic murmur are mitral regurgitation, tricuspid regurgitation, and VSD. If you see a description in a board question of a holosystolic or pansystolic murmur, think of these three conditions. A patent ductus arteriosus causes a continuous machine-like murmur. The murmur is continuous, meaning it's present in both systole and diastole. Why is this the case? The reason this happens is because the conduit for a PDA is from the aorta to the pulmonary artery. The pressure in those chambers does not swing up and down like the pressure inside the heart. Therefore, there is always some driving force for blood flow, even in systole and diastole. So it's a continuous murmur, and it's described as machine-like. And I'll play you an example of it now. Now let's talk about maneuvers. These are basically tricks that you can perform at the bedside with the patient that may increase or decrease the murmur. And based on the change in the murmur with a particular maneuver, you can use that information to make a diagnosis. One of the maneuvers we'll talk about is the leg raise, and that's shown here in this drawing. There are two maneuvers that can be performed to increase the preload and the venous return to the heart. The first one is leg raise. That's what I showed you on the last slide. If you lie the patient flat on their back and lift their legs over their body, the blood will fall backwards toward the heart, and this will obviously raise the venous return and the preload. The same physiology occurs when patients squat. When they squat, blood in the legs is forced back towards the heart. Basically, you compress veins in the legs and push blood back up towards the right atrium. That raises the preload and venous return. The two maneuvers that decrease preload and venous return are the Valsalva maneuver and standing. I'll talk about the Valsalva maneuver on the next slide, but this maneuver raises intrathoracic pressure, this compresses veins, and it decreases venous return and preload. Standing also has similar effects. When you stand, blood falls towards your feet away from your heart. Most murmurs increase with more preload and decrease with less preload. The only two exceptions are hypertrophic cardiomyopathy and mitral valve prolapse. So in general, you can think that maneuvers like leg raise and squatting will usually make murmurs louder, and maneuvers like Valsalva and standing will usually make murmurs quieter as a general rule of thumb. To perform the Valsalva maneuver, you ask the patient to bear down as if moving their bowels. You can also ask them to blow out with their mouth closed. When you do this, phase 1 of the Valsalva maneuver begins, which lasts a few seconds. In this phase, the thoracic pressure rises because the patient is bearing down. That higher pressure will compress veins in the thorax and raise the pressure of blood stored in those vessels. That higher pressure is transmitted to the right atrium, and the right atrial pressure rises. The driving force for blood flow back to the heart is the difference between pressure in the peripheral veins and pressure in the right atrium. So when the right atrial pressure rises, there's less driving force for blood to return to the heart, and therefore the venous return falls. A second effect of phase 1 of the Valsalva maneuver is that there is a temporary transient rise in aortic pressure caused by compression of the aorta and other arterial structures. This is sensed by baroreceptors, and there's a reflex fall in heart rate and conduction through the AV node. Because of this effect of phase 1 of the Valsalva maneuver is effective in slowing the heart rate and breaking some types of tachycardias. After a few seconds, phase 1 ends and phase 2 begins. In phase 2, there's a fall in preload to the left ventricle because of the drop in venous return in phase 1. This lowers the cardiac output. This also lowers the blood pressure, the opposite of what happens in phase 1. That is sensed by baroreceptors, and therefore the heart rate goes up in phase 2 of the Valsalva maneuver and AV node conduction increases. But the major points you want to remember in terms of heart murmurs is that the two effects of the Valsalva maneuver are to drop the venous return and drop the preload on the left ventricle. And because of these two effects, you are going to see a change in murmur intensity. Murmurs that affect afterload are shown in this slide. If the patient does the hand grip maneuver and clenches their fists, this will raise the afterload on the left ventricle by slightly raising the blood pressure. To decrease afterload, you can administer a drug called amyl nitrate. This is not done in the modern era, but it used to be done decades ago. It's a vasodilator that is short-acting, and if you administer this drug, you will lower the afterload, and that can change murmurs. The effect of changes in afterload on heart murmurs depends on the type of murmur. In so-called backward valve disorders, murmurs tend to get louder with more afterload. These are disorders where blood is flowing backwards to generate the murmur. So for example, in aortic regurgitation, blood flows backwards across the aortic valve. The same is true of the mitral valve with mitral regurgitation. And in a VSD, blood is usually flowing from the left ventricle to the right ventricle, which is not the normal direction. So anytime you have one of these backward valve disorders, when you raise the afterload, there's more force pushing blood backward and more force resisting the normal forward flow of blood, and that tends to make the murmur louder. Forward valve disorders are disorders like mitral stenosis and aortic stenosis. You want the normal forward flow of blood to generate these murmurs. So when you raise the afterload, these become softer because there is less pressure difference to move blood forward and more forces resisting the forward flow of blood. And then finally, mitral valve prolapse and hypertrophic cardiomyopathy are really special situations. These two murmurs get softer with more afterload. The reason is that when you raise the afterload, the left ventricular cavity size increases slightly because it's harder for blood to leave the cavity. And when the cavity gets larger, the murmurs of mitral valve prolapse and hypertrophic cardiomyopathy decrease in intensity. When you're faced with a board question involving a heart murmur, the most important thing to do is read the question stem carefully. Most of the step 1 questions I've seen, I can answer the question before I even listen to the murmur just based on diagnostic clues in the question stem. So for example, if the question stem describes a young female who is otherwise healthy, this is the classic demographic for mitral valve prolapse. If the question describes a healthy young athlete who has syncope, this is the classic scenario for hypertrophic cardiomyopathy. Mitral stenosis is much more common in third world countries where children have limited access to antibiotics for strep throat, so usually mitral stenosis will present in an immigrant. This is also a common presentation during pregnancy because blood volume increases in pregnancy, and that can make mitral stenosis that was previously asymptomatic become symptomatic. IV drug abusers classically develop endocarditis of the tricuspid valve and develop tricuspid regurgitation. And then patients with Turner syndrome or aortic coarctation are at increased risk for a bicuspid aortic valve. And bicuspid valves develop stenosis at an earlier age, and they also develop aortic regurgitation. And then finally, patients with Marfan syndrome are a classic demographic to develop mitral valve prolapse. I'll finish with this slide summarizing commonly tested heart murmurs. Aortic stenosis and hypertrophic cardiomyopathy are a systolic crescendo-decrescendo murmur. MR and VSD are holosystolic murmurs. Aortic regurgitation is a blowing diastolic murmur. Mitral stenosis has that opening snap followed by a diastolic rumble. And then finally, a PDA is a continuous murmur. And the right-sided murmurs involving the tricuspid and pulmonic valve are just like the left-sided murmurs, but they're heard in different locations. And that concludes our video on